Welcome to this talk in our series, which is all about sex and sexual function after a hysterectomy with me, Ali Taylor, on your hysterectomy fitness recovery course. Now, before we get going, if you can hear any hooting in the background, I'm recording this all the way from Vietnam. And if you know anything about Vietnam, you'll know that the traffic never stops, the motorbikes are incessant, and they hoot constantly. So I've tried to close everything up, but you can still hear it, so I apologise for that. Any scraping noises are because our room is below the restaurant. So apologies for the noise, but hopefully it won't interfere too much. So we're going to be delving into the impact of a hysterectomy on sexuality and sexual function. And when I was researching this, I thought it was going to go a particular way. And it actually threw up quite a few interesting things as I went along. So we're going to go in a little bit of a direction which I didn't originally anticipate. And this is a topic which I feel probably needs a lot more research to be done on it, and needs that research to be better. And I'll talk about why a little bit later. We're going to look who is at most risk of continued pain and sexual dysfunction after surgery, who should see an improvement, which you might be surprised to hear is most women, and factors which could cause a drop in desire and what you can actually do sexually. We're going to touch on vaginal cuff closure, and we're going to talk about how that relates to sexual function in terms of the length of the vaginal cuff as it remains after a hysterectomy. So let's get into it. Now, it should be noted, and this is a strong disclaimer, that the research into female sexual health and sexual satisfaction, and I feel like sexual health and satisfaction are almost two separate but interwoven things. It's really quite poor, and a lot of the what we call cohort reviews, which is when some authors will review all the existing literature, and these are considered good quality research because they look at a lot of literature and they dismiss the poor quality papers, so you're generally left with the better quality papers. The reviews are telling us that the research is poor, the questions are poor, there's often a high risk of bias, and so this area really does need some people to grab it by the horns and look at it. Although it needs better research, it's also difficult. Some of the questions that come up are around ballooning of the vagina after a hysterectomy. I'm not sure how you study those things, because I feel like it would probably be unethical to pop nodes and the sort of little sensors that monitor various things into a woman while she has sex. I feel that there's ethical issues around that. So a lot of the research is done through what's called retrospective questioning, which is when women are questioned after a hysterectomy, but often several years after a hysterectomy, at which point recall may not be as good as it was immediately after. Prospective studies are better, which is where the authors will take women before their surgery and at various points after it, so that the women are going through it and the recall should be accurate. And a lot of them are done by men, therefore the questions are often quite poor. When I was looking at studies, some of the questions were simply, is your sex life the same as, worse, or better than prior to your surgery? Or do you have intercourse the same amount, less, or more than your surgery? And I feel that these questions really do not encompass the gamut of emotions and feelings a woman will have around sex. And I think importantly as well, many of the questions asked by the researchers assume heterosexual coitus. By that I mean a male and female couple that are having penetrative sex, and they are basing their assumptions of whether a woman is having successful sex based on whether they are having successful penetrative sex. And I feel that in this day and age we probably need to move on from that, especially as we know that most women orgasm via clitoral stimulation as opposed to vaginal. So as we look at this whole subject, I really just wanted to point out that, as with many areas of research, whenever it involves women, it's generally poor, the questions are not good, and often the questions are asked by men who have no idea about women. So just putting that out there. So let's look at different factors. For me, as I've worked my way through the literature, there have been three predominant factors when we look at female sexual satisfaction after a hysterectomy. The first is the physical, so this is the actual effects of the surgery, the condition of the nerves, the nerve endings, blood supply as it relates to surgery itself and what remains. And that does depend a little bit on the type of surgery. A radical hysterectomy is going to remove more tissue, therefore more surrounding nerves and blood vessels, than a subtotal hysterectomy. So we need to really look at how much that potentially affects stimulation and arousal. The cervix, does it stay or is it removed? Sometimes the upper part of the vagina is removed, particularly in radical hysterectomies which are performed for cancer. There is a hypothesis that hysterectomy disrupts blood circulation to the pelvis entirely, which impairs adequate lubrication and potentially impairs swelling. So when we are aroused, we get a swelling of the vagina, which helps to induce lubrication and therefore makes penetrative sex more comfortable, or really all sex. Even for clitoral stimulation to be successful, you actually need lubrication, otherwise it's just actually quite painful, which is, I feel, one of those things that men should be taught, is if they just go straight there and rub, it doesn't really do very much except cause pain. So we're going to look at that with the actual physical effects of surgery. We're going to look also at psychological factors. So these are things like fear, the fear of the surgery itself, the fear of having sex after a surgery, any worry about having sex after a surgery, and then any beliefs as well. So beliefs are what you physically believe the surgery is going to do to your sex life or your body. Beliefs are actually very, very important, and we should not dismiss them quickly at all. Sexual dysfunction at baseline. So this is any sexual issues or problems you have having sex prior to the surgery, and these might be more important than we think. Negative expectations also is something that comes up in the literature. If a woman expects that her experience of sex after a hysterectomy is going to be negative, does that pan out or not? And there are studies on this. If a woman assumes it's going to be negative, will it actually be negative? The thing that is used across all studies to look at this is something called the Female Sexual Function Index, FSFI for short. And a score of 19 or lower is considered a low score. Anything above that is considered, that we're kind of okay, but the higher the score, the better. We're also going to look at confounding factors, and these are things that may be associative, they may be correlation, they could be causation, but more like correlation. And often when you get a mixture of several confounding factors, that can lead to overall satisfaction or lack of when it comes to female sex. So let's look at physical first of all. Here is your anatomy lesson for the day. In front of you, you see a uterus, along with fallopian tubes, ovaries, the cervix, which you see is right at the bottom of the entrance to the uterus itself, which is why it's often removed with many surgeries, because it really does form part of that uterus complex. And then the vagina we see is almost its own separate little canal that the cervix dips into. So when we look at types of surgery, we have a subtotal hysterectomy, which is where just the uterus is taken. Sometimes they will take fallopian tubes, and sometimes they will take the ovaries, which is called an oophorectomy. Generally, if a woman is not having the hysterectomy for cancer and is premenopausal, they will try and leave ovaries unless there are cysts or issues with the ovaries, and that's for hormonal preservation. A total hysterectomy will tend to remove the cervix as well, and usually the fallopian tubes and ovaries, although we can still have a total hysterectomy with ovary sparing. You will also get a radical hysterectomy, and that's where they tend to remove more extra tissue from the top of the vagina as well. And you will often get removal of more tissue around the uterus, around the other organs linked to the uterus. So you may get more removal of lymph nodes, and ligament potentially around the area that cancer perhaps may have infiltrated or could infiltrate. So with cancer, they always want to have a good margin of removal of organs that are affected. Women have hysterectomies for a variety of reasons. Those reasons often affect physical and sexual function. So fibroids, I had fibroids myself, and I had 8 of them, and they had actually shifted my bladder. My uterus had enlarged so much with these fibroids, it had pushed my bladder up out of my pelvis slightly and was compressing up on the right side of my gastrointestinal organs. I also had fibroids pressing into the nerves at the base of my sacrum, so I had leg pain, and they were on the inside and outside of the womb. So I basically had every type of fibroid you can imagine. Now, for me, sex was pretty much impossible. It was excruciatingly painful, and I actually realized that it wasn't just a psychological problem. I wondered if I had some sort of fear, or you can actually get a dyspareunia, as I think how you pronounce it, which is painful sex. And sometimes it can be a fear-based thing. It hurts once or twice, and then your brain knows to expect pain. It was when I had my smear test and they couldn't get the speculum either that I realized there probably was a problem. And for me, the fibroids were definitely creating a lot of pain with sex. So once the uterus and the fibroids were gone, for me, that issue was entirely removed. Endometriosis sufferers will often find similar, the thickening of the endometrium, which is the womb lining, that can create difficulty with penetrative sex. Cancer obviously can create a lot of pain and a lot of problems with sex. Heavy bleeding may create painful sex. Hyperplasia, which is where we get an increase in tissue size. All these things will reduce the size of the opening, therefore how much can get through in terms of the vagina. It could also create problems with lubrication. So you end up with a bit of a reduction in desire with many of these problems because it just hurts, so you don't want to have sex. And I think for many women, that fear of will you still have that same pain after the surgery is very, very real. Reduction in desire or lack of desire is a problem that could be entirely separate to the physical reasons why a woman has surgery. And I feel that if there is a lack of desire completely separate, that probably requires specialist intervention. And you can get sexual therapy where you discuss and uncover what's causing that anxiety or that reduction in libido so that you do actually want to have a healthy sex life. Hormones are also linked to that. So menopausal women will often see a reduction in libido because estrogen and progesterone and testosterone all reduce. Testosterone in particular is very important for a strong desire to have sex. So menopause, and again cancer, because of the effects of hormones on cancer and also the treatments, will often lead to a lack of desire. So that's your anatomy lesson, which we can keep in mind as we go through. So we stay with the physical. This is a picture of the nerves. So you see the spine, all the little tiny bones there of the spine. And then you see the heights at which they exit. So you'll see within our thoracic spine, so thoracolumbar, around T10, T11, T12. So your bottom 3 thoracic facet joints, you see the splenic nerves exit, and these innervate the colon. They are some of your gastric nerves. They innervate the bladder, but you'll also see they go down to the uterus and the ovaries and the cervix. If you look further down, you'll see the pelvic nerves joining the splenic nerves to go down to the uterus, the ovaries, and the cervix. Coming right off your sacroiliac nerve 3 and 4 level is what's called the pudendal nerve, and this is the one that serves the vagina. And when we move to the next slide, you'll actually see the entire area that nerve covers. So when we look at this, we can see one lot of nerve supplies the uterus, vagina and ovaries, and another nerve supplies the vagina. Now when we look at the research and reviews of the research in terms of physical changes to his sexuality after a hysterectomy, they really have looked at how nerves may or may not be affected and to what degree. In the past, there have been hypotheses about hysterectomy interrupting nerve supply, causing a reduction in sensitivity, which could lead to a lack of arousal and lubrication. They've looked at whether scar tissue in the upper part of the vagina can prevent full ballooning and therefore diminished arousal. They've looked at whether the lack of the cervix could lead to diminished lubrication. And some researchers also looked at how much of this impacts satisfaction. Although, as I said, it's not always great research. The questions aren't always particularly brilliant. And the assumption is that it's heterosexual and penetrative. So when we look at this diagram of where those nerves exit, we see very clearly that the vagina and therefore the clitoris has its own separate innervation supply from the uterus. Very interestingly, and I did not know this before looking at all of this, 90% of women climax from clitoral stimulation. 90%, 90. Only 10% of women appear to orgasm or have better orgasms through vaginal stimulation, which may also include uterine and cervical contractions. So that is a thing for 10% of women. The uterus and cervix contracting at the moment of orgasm does seem to be important for about 10% of women. So those women are most likely to be affected by the loss of the uterus and the cervix. Now, I don't know how you tell if you orgasmed better with your uterus and vagina, so you are one of those 10%. I know for myself, I have always definitely orgasm through clitoral stimulation rather than vaginal stimulation, and if I ever did manage to orgasm through vaginal stimulation or penetrative sex, it wasn't actually particularly strong. So my preferred way was definitely always clitoral stimulation, or is clitoral stimulation, I should say. So perhaps there's something there if you're a woman who always had stronger orgasms from penetrative sex, but perhaps you're one of that 10%. But I think for most of us, we're going to fall into that 90%, which means we're going to be less affected by the loss of the uterus and the cervix because of where these nerves serve. And if I show you this next slide, the green little branches are the perineal branch of the posterior femoral nerve. So that's a nerve that goes sort of the femoral nerve is a big nerve, and you get the femoral artery as well that starts to come down off the sacrum down towards the legs. You'll see we have a little red nerve at the top called the genitofemoral nerve, so that's serving the genital area, and it also comes off that big femoral nerve. And then this pudendal nerve, which is the yellow one, is the one that you saw coming off your sacroiliac facet joint 3-4. And you'll see this actually surrounds the whole of the pelvic floor area. Your pelvic floor is actually quite big. It covers a whole sort of figure 8 space from the front of the pelvis to the back. It encompasses the clitoris, the vagina, and the anus. And we'll see this pudendal nerve, it covers it all, and it really goes very close to the clitoris, which is why for most women, it's clitoral stimulation which gives us better orgasms. So 90% of women, physically, once the reason for surgery is removed, the fibroids, the endometriosis, the hyperplasia, whatever it is, the pain and dysfunction related to that condition is gone. Sexual pleasure and satisfaction should return unless there is any other baseline sexual dysfunction, in particular a psychological dysfunction related to sex. And that's a very real thing, but it requires very real help from a trained professional. So I think that's quite interesting, and it's quite exciting that really for most of us we can live very happily without our uterus, without the worry that it was giving us, and without the worry of pregnancy, if that was a concern, which for many women it is. For many women it's also distressing if they still wanted to have children, but that risk of pregnancy fear does go for many women, depending on your age. Okay, while we're still on physical, does vaginal length affect sexual function? So this comes up in social media groups, and it's also been discussed on some other groups and some things on YouTube. I'm just going to have a swig of water. And it's interesting because for a lot of people you would assume that vaginal length and a shorter vagina tract would affect sexual function. Perhaps a man or a sex toy would struggle to actually get in. So we have studies. We have cohort analysis that have reviewed multiple studies, and they've looked at the length of vaginal cavity after various different types of hysterectomy, as well as whether the cuff was created horizontally or vertically in terms of how they've sewn it up. They found that vaginal hysterectomy, which would make sense, seemed to shorten the vagina the most, but only by an average of 0.63 centimetres, so just over half a centimetre, which isn't very much. This particular study looked at sexual function and urinary incontinence, and it looked at the symptoms in women 3 and 12 months post-op, and they actually had the same satisfaction scores of women with laparoscopic or robotic surgeries, and the robotic and laparoscopic surgeries tend to be associated with keeping the most post-operative length in the vagina. So it didn't really seem to be of clinical significance, which means it doesn't matter, basically. You've lost a little bit of length, but it doesn't really seem to affect any function. Horizontal cuff, interestingly, was associated with a shorter vaginal length than a vertical closure by 8 to 10%. The research is a little bit kind of about whether this has a negative association or it perhaps produces a new pain due to penetrative intercourse. So the outcome is a little bit unclear, although the authors are recommending that a vertical cuff closure is used just to be on the safe side. Now, vaginal hysterectomy is most often used for prolapse. So the rationale for the extra shortening could be that more tissue is taken in order to successfully treat the prolapse and avoid recurrence. Abdominal hysterectomy tends to be done more often in women who are older or more overweight because of the risk of complication. So type of hysterectomy tends to be linked to type of reason for the hysterectomy and weight and age of the patient. Studies have, interestingly, also been done on post-hysterectomy urethral length. Your urethra connects your bladder, so urine goes along it. And they've actually found that urethral length is also largely unaffected by the surgical route, and that also urinary incontinence symptoms don't get any worse if any shortening does occur. So if that's a worry for you, rest assured it doesn't really seem to have any impact. Radical hysterectomy, of course, requires the most amount of tissue to be taken, which can result in the shortest vaginal length. Potentially more nerve and blood supply removal, but this is necessary for preservation of life. So I would always say preserving life has got to be your most important factor. When we look at whether a shorter cuff affects a woman's quality of life or sexual function, they do need to do more research on this, which is why the authors of these studies have recommended vertical closure be used just to make sure if you can take a little element out of play, then do it. Okay, psychological factors. So this is quite a big pot of questions, but what comes up, particularly what comes up here in questions to me when I start working with women one-to-one, and what comes up a lot on social media is, how will it feel? This is fear, this is worry. How will it feel? Will it hurt? Will it feel different from my partner? Will I injure myself or the surgical area? And it really doesn't feel that different, I have to tell you. If you haven't had sex after your hysterectomy yet, it doesn't feel that different. You might feel a little tighter in there to begin with, and you definitely need to spend a little bit more time on foreplay, but honestly it really does feel better than before once the problem for needing the hysterectomy is gone, because the pathology is gone. It's not there. So for most women, the removal of the cause of the problem has a really positive effect on sexuality post-operatively. The exception really being women undergoing hysterectomy for cancer because of the treatment, which is ongoing before and during the surgery. So women undergoing hysterectomy for cancer, they do have a massive psychological worry because that fear is very real. There's more treatment that has to happen after surgery quite often. Interesting fact, 79% of women report negative expectations of surgery and the surgical outcome, particularly related to sex, when they have got their information from the media. And that stat actually comes from a paper back in the 90s based on magazines and newspapers, and we're now in 2022 and we have social media and Google. And I would not be surprised if that percentage was higher, because we love to Google and we love to express our thoughts and read others in social media groups. And there are hysterectomy groups on social media. They can be very supportive. Women can find a lot of help. But there is also a lot of catastrophizing in those groups. And if you see a lot of catastrophizing, it can also create fear in you. And we know that if you believe something or have a fear of something, you can almost think it true. So we must be really careful about social media, Google, and where we get our information from. Now, the other important thing when we look at psychological factors are things like pre-surgical depression, surgical fear, pre-surgery dysfunction, negative expectations, and how these relate to the female sexual function index and the score that a woman gets. And for a very long time it was proposed that having depression, having fear of surgery, having lower expectations would lead to a lower FSFI score. More recent papers have kind of debunked this and found that it's not really the case, and women's scores do go up after a hysterectomy regardless of whether they had preoperative depression or fear or negative expectations. But very surprisingly, they found that the biggest factors for a lower FSFI score were being married or living with a partner and sexual dysfunction prior to surgery, which again brings into play there's more going on than just the physical problem. So there's something that needs to be dealt with by a trained professional in sexology and sexual health. And this thing about women having lower FSFI scores if they were married or living together, the paper reports it as surprising. I found it surprising. I was like, I wonder why. And the hypothesis, and it is just a hypothesis, is that when women are in a long-term relationship, they tend to have very fixed patterns. Women living alone might be more confident to explore and might be more confident to just tell a new partner what they like. So those of us who are married may just be in sexual ruts, basically. So I thought that was fascinating when I read all about that. Now, confounding factors. So these are things that contribute positively or negatively to sexual function. So things like your relationship with a partner. So here, being in a good relationship with a partner where you feel supported, and also a relationship with friends, which goes into socio-psychological well-being, having good general health, having freedom from severe life stresses, an absence of financial worry. These things appear to correlate to having a more successful sex life, to having more positive sexual function. As I said, being married or single seems to be a confounding factor, with single women tending to have better sex generally. The effects of hormones. So oophorectomy, if it's performed premenopausally or post, causes a reduction in estrogen and androgen levels. That's your testosterone. And as testosterone, estrogen and progesterone dip, we tend to have less desire, which is why I do believe HRT is very important, particularly with a surgically induced menopause, which we're going to talk about another week. Unless you're having your hysterectomy for cancer or for any reason you cannot take HRT, in which case the doctors will look at alternatives. But HRT bumps the estrogen back up. Estrogen helps to make testosterone, so it's really quite important for desire to keep some estrogen coming in. Socio-psychological well-being, so this is a lack of health problems, support of friends, and the ability really to reframe problems. These are important predictors of increased sexual satisfaction after hysterectomy in some studies. And also when we look at hysterectomy and mental health next week, we're going to look at the effect of anxiety and catastrophizing on recovery generally, because a positive attitude to surgery and recovery tends to lead to better outcomes. And that's not just because you think yourself better, but it's because you do more actions that lead to a positive outcome. So being able to reframe problems is important. The indication for the surgery does seem to be a little bit linked to sexual function and positive sexual function after surgery, as does the type of surgery a little bit. So as we said, if you're having a radical hysterectomy for cancer, then you do tend to have more worry. You're going to have more treatment afterwards. And also age. So age linked to menopause. The older we get, the less collagen we have in our body. As we talked about when we looked at healing, collagen makes up every single part of our tissue, our connective tissue, our skin. And as we age, it reduces. And we have collagen in our vagina. And that collagen degrades as we get older. We struggle to lubricate as much, and we actually have vaginal atrophy, which sounds lovely. But it basically means in the same way our muscles shrink, our vagina can shrink too. Another reason to potentially sign up for HRT if you are able to, because I don't know about you, but I don't particularly want an atrophied vagina. So these are all factors that just add to whether sex is enjoyable after your surgery. So just as we conclude this talk, and I hope you found this interesting, I really spent longer looking at all of this research than I thought I would, because I just kept jumping from paper to paper and delving into more stuff. So these are my tips. Now, these are not science-backed. These are just what I found helpful and what I recommend to my one-to-one clients. I'm sure you can find more tips available on the internet if you would like, but these are what I think. Sex with a partner can feel like pressure, particularly if you've got fear around what it's going to feel like for you. So I say solo sex, a little solo session that first time, so you take away the pressure of performance with a partner and focus on you and your pleasure. So that's what I always say, and people laugh, but it's so true. And we probably should talk about female masturbation more, because it's an important part of female sexual health and well-being, and knowing what you want as well. Take your time on your own or with a partner. Take your time. Enhanced foreplay and knowing your erogenous zones can actually increase vaginal ballooning, arousal and lubrication. And I'm sure most men do not know that the back of the ear, the inside of the thighs and the tops of the shoulders and the neck are all erogenous zones. And if they spent some time there, then they would probably actually increase arousal in a woman, so that you get increased lubrication, that increase in ballooning, so that then when you come to penetrative sex or using a toy, it's actually easier. Things go in better when we are expanded and well lubricated. And on that note, lubricating gel, especially if you've gone into menopause, because you will produce less lubrication as you go through and after menopause. Communication, it sounds silly, but taking your time to talk to your partner about what works for you. As women, I don't think we always do this well, and it's actually important, because I think men, for many of them, they just want to jump straight in. They kind of want to rub your nipples, rub your clitoris, and then wham bam, thank you ma'am. And if they took more time, if they understood how you work as a woman and what turns you on and what actually gets things going, then that would lead to more more successful sex for both of you, because it would also be more comfortable for him or for her, and that's just got to be better all over. Try massage, sensual massage, try toys. There are so many out there. Try learning about techniques such as tantric sex, where you go on this exploration mentally and physically without actually touching the genitalia, and it makes things very, very sensual. And if we make sex a sensual act, then we can get a lot of pleasure from that. Pelvic floor, ladies, another reason to do your Kegels. There is good research, and this is good research now, that your pelvic floor may strongly correlate to an increased orgasm strength and potentially even frequency. So do your Kegels, have a strong pelvic floor, and if you try doing pelvic floor while having sex, it can make your orgasm stronger as well as just being a good way to do your Kegels, because you have that feedback. And men actually quite like it as well. And the last thing is to relax. So relax as you have sex. Don't worry about performing and having to get there fast. Breathe, because your diaphragm is fascially linked with your pelvic floor. And if you actually do pelvic floor Kegels and take deep breaths while, whether it's having penetrative sex or being orally stimulated or manually stimulated, you can actually have a very deep, strong orgasm by including deep breaths. So that's my top little tip. So as always, I hope you found that interesting. Like I said, I found it really interesting, which is why I spent quite a long time looking at the literature on it and really uncovering different things that I hadn't thought of as I went about this. If you do have any questions, as always, here's my email, here's Instagram, Facebook, and our website. Easiest way to contact me is probably DM on Instagram, because I'll always respond to that quite quickly, but email works too. So get in contact if you have any questions, and I hope you enjoyed that.